Okay, hi everybody. Good afternoon. Jenna Heiss. I am the implementation director for the Office of Mental Health here in New York and the Suicide Prevention Center of New York. I'm thrilled that you are here and that you have stayed for the morning, hopefully. Um, I am okay. We're starting up some chat, so that's great. We do have a monitor and a moderator that will be looking at the chat and answering the chat for us today. This will not be an open question and answer session. It will be a structured panel. Well, I will be asking questions to our two distinguished guests here. And then at the end, we will open it up for 5 to 10 minutes of your questions. And I do want to thank you again for coming today. And this session will run until 12:35. And this is our closing session. As I mentioned, I have Dr. Edward Coffey here, and I have Dr. Michael Hogan. These folks really are the backbone and the originators in so many ways, along with a few others that have been mentioned today, of the zero suicide framework and movement at this point, and we can definitely call it that, that has really revitalized suicide prevention. And Dr. Ed Coffey is really, in so many ways, given us the origin story today, and we really stand here on his back as a giant in the field, and hopefully we're not hurting your back. I don't mean that literally. And then we have Dr. Mike Hogan, as we have said, the co-founder of the development of the rest of the movement from all of Dr. Coffey's work with his team. And so I'm pleased to have them here. We are going to jump right into this session. I certainly allow them anything they would else like to say about themselves as we move forward. So I will move us into speaker view. They will have about 3 minutes to answer their questions, but I'm not going to do a gong or anything. So don't worry about that. But I do have a timer, but if you're going on about 6 minutes or so, because I do want to be able to get through our questions today. So I will move us into the speaker mode here. Looks like we have Mike on speaker. Yeah, well, maybe I'll just keep us in gallery. That's fine. And excuse me, I want to start out with a question that I hope folks were able to tune in today and hear all of the talks this morning. And if you did, I wonder if you are, like so many of the questions that I've already heard today, asking and wondering to yourself, you know, are we even in a position or how would we, you know, and should we even, you know, consider doing this thing, zero suicide? And so I want to turn this first over to you, Dr. Coffey.
Well, that's a great question. And I think it is important for teams to take the question seriously and spend some time talking about it together. There isn't one, quote, doing zero suicide, end quote. There are as many approaches to suicide, to improving suicide care, as there are practitioners out there. And so I think the first step is to decide what is it that we as a team want to try to accomplish specifically. And there's no wrong answer here. Any attention that's being paid to improving suicide care, in my view, I'm sure Mike would agree, is a good thing. We can do better and we need to do better. Now, having said that, there is an incredibly wide range of activities that teams can then begin to engage in. It could be something as straightforward as a process improvement project around, let's say, suicide screening or around access to care. I don't mean to make these things sound simple. Access to care is a very difficult, very challenging issue. On the one hand, and then on the other, you could go all the way to viewing zero suicide as a driving force for an overall transformation of your healthcare system so that you improve not just suicide care, but all of your aspects of care. And that's, as Mike mentioned earlier, that's kind of how we got into it. And then there's everything in between those two goalposts that a team could pursue. So it's really important to be clear on what it is that you're trying to accomplish and how you're going to measure it. It is possible, for example, that you could do lots of things to improve, let's say, depression care or mental health care, and not move the suicide needle. So you could improve access in your system. You could improve suicide screening in your system. And in theory, still not move the needle on suicide behavior, on suicide outcomes. So it's important to understand that and to be clear, what is our goal? What are we trying to do? How are we going to measure it? You know, the usual approach to quality improvement. And then from there, decide, okay, what aspect of this pyramid that I showed earlier today are we interested in pursuing? I'll pause there so I don't get gonged.
Okay, thank you, Dr. Coffey. Dr. Hogan, what would you add here?
Well, I guess just in think about this, Jenna, that one might answer or ask the opposite question, which is, should we not try to reduce suicide or suicidal behaviors or the morbidity, the pain that goes with living with suicidal thoughts and feelings? And you know, asked that way, it's hard to it's sort of hard to come up with a no answer to that. And then, so if the answer is yes, we should do something, where should we go? And I think Dr. Coffey's answer to that, I agree with it wholeheartedly. It's, you know, nothing is accomplished, nothing much is accomplished on a solo basis in health and mental health care these days. There's always a team involved, and so a conversation with whoever the team is going to be is a starting place. You know, sort of. I think Ed made another important point, which is there are, to rephrase this a little bit, if you want to really reduce suicide, you should do something that's relevant to suicide. There are other activities that might be vital, but they might not be directly related to reducing suicide per se. That's one of the things we've learned in this journey. You know, for example, even though we know that depression is significantly increases risk, the very great majority of people with depression don't attempt or complete suicide. The same is true for any other risk factor. And so I would say, if you answer the question by saying, yes, let's try to do something about this, then I think coming to consensus as a team about the strategy and doing something that focuses on suicide per se and not on other activities seems to me to be the way to go.
Yes, and I'm switching the order a little bit here, but you know, given that, Dr. Hogan, in your travels with zero suicide, but also given what you talked about in your presentation today, what do you see as the barriers to systems really taking on suicide prevention as a core goal? You did speak to that some, and I'm curious now as to what you think about that.
I guess I'll start, Jenna, in addressing that by going to the other side of that question, which is, what do the places that take this up well have in common? And they've all got committed leadership. And so if one's approach to this is half-hearted, the results are going to be half-baked. And the people that have done this really well, and you saw this in your leadership in Texas, are the places where there was passionate leadership. Actually, we know from some of the research on change in healthcare that often there are two kinds of leadership that are really critical in changing practices in healthcare. And one of those is the kind of leadership that goes with, formal leaders. There's got to be somebody on the executive team or the leadership team that is not necessarily thinking about this every day, but has got the back of the people who are working on it. There's got to be a formal leader who is the who just has the interests of the team and the goals of this project in mind. And the other kind of leadership that's really critical is frontline leadership. This is likely to be a respected clinician who's committed to this, because commitment is equally important, or maybe even more important than skill in this regard. And so thinking about if you're going to get into this, who's going to be the formal leader and who's going to be the frontline leader, I think are really good questions to think about. Places that don't have those are not going to succeed.
I agree. I've seen that in my work across the country. I think sometimes like to call it I think the power and the passion. Yeah, somebody who has the clout to make those changes, as we've talked about in leadership, but without the passion and that commitment from the folks on the ground, some of those natural leaders throughout the organization that folks go to. I really find that those organizations struggle as well. And Dr. Coffey, you gave us a lot of examples of really in your origin story, what you did as a leader. And I've seen you be able to help other organizations and speak to that and be able to then leave and then go to Manager and do that. So would you be able to now kind of share your experience about that?
Well, again, I would agree with Mike that it starts with leadership, and that's not me trying to blow our own horns here, but it's just stating the obvious fact that if you don't have the commitment of those who oversee the resources and the priorities of the organization, then it's just not going to work. So it's got to begin with a passion and a conversation with the leadership, however that's defined, to convince that leadership that this is a priority, not simply today's priority, not the flavor of the month, but it's something that we've got to do going forward. It's just like Mike said, we got screening for cholesterol or asking about seatbelt use. This is part of what we need to do to provide good health care. This is healthcare, and it needs to be done. Now, that said, we have to appreciate the role that leaders are in. So they might be on board, but they might be getting scared to death, thinking that what's going to come next? You're going to ask me for $1 gazillion. And so part of the ask has to be followed by, here's how we think we could do it. Here's an approach that we think would work, and it's not going to cost $1 gazillion. As long as you the leaders, give us some room to be able to move some resources around to a place where we think they're better invested than they might be right now. And maybe every now and then we need a little bit of help from you on this, that, or the other. Like maybe I don't have to give you this particular report on the status of trees in the backyard of the hospital today. Maybe you don't need that today. Maybe you'll let me spend my time doing something else over here. So it's like anything else. It's working with your leadership and how you engage that leadership in the work that needs to get done. The other important point is that once you get to go ahead, you've got to make sure that you put your measurement systems in place. That's another very difficult part of this work, because almost invariably they don't exist currently. if the system hasn't been focused on this issue, there certainly are no metrics around it. And so building that measurement enterprise is really, really important. And then, and fundamentally, that whole culture of restorative justice, the just culture that we talked about earlier, none of this is going to go anywhere if people are scared to death that you're going to punish them if they mess up. And so and that to me was, I thought the hardest part of the work that I did was just making sure that everything I did and everything that I said was sending the message that we're going to be about a just culture. We're not going to be about a punitive culture. And it's you can make a mistake here, not even knowing that you're making it, you know. And so that's why I said earlier we had to do things like remove from our instant review process the question, who did it, you know, or who was in charge. Even things like that can send a very, very subtle but important message. So it you just have to try to work on it every day and be transparent. Make sure your team feels the same way. Hold yourself accountable as a leader. Make sure if you take a misstep, you own it and try to correct it.
Such important and powerful experiences and wisdom that you bring with that. Thank you. One of the things that we talked about when we talked about having this panel, Dr. Coffey, was, you know, what are kind of the one or two issues that could really make or break that, you know, getting this thing started, you know, kind of, you have a lot of experience with sitting down and kind of really rolling your sleeves up with folks as they try to do this work. Could you tell us a bit about that?
Well, I guess you're asking me really about implementation, assuming that we have the buy-in of the leadership and we have some agreement on where we're going in general. I think then the issue becomes one of how do you do improvement work in your organization? You know, what is your model for improvement? And again, there's no one right answer here, but you need to have a model for how you improve. And so I always start by, when I'm helping organization, I go around the table and say, just give me 10 seconds on your model for improvement, you know, in the room. And it's very interesting, you know, the answers that you get. We're the same way we start. You know, our team wasn't all on the same page about model for improvement. So that's kind of basic. You gotta get on the same page about that, and then let that model guide your work. It's, if you have a good model, if you take the IHI model, whichever you adopt, but that model will guide the work that you do subsequently. So that's the place that I always start. What is our model for improvement? How do we improve the care that we provide?
Great, thank you. Dr. Hogan, you know, certainly anything you want to talk about this, you know, I can't help but think of, you know, you've really got this national perspective, you know, from being a Zero Suicide Institute faculty in your past, and, you know, the kind of that 50,000-foot view that you're able to get from that. Yeah, anyways, what are your thoughts here?
Well, I've had several thoughts about this process of starting and then of continuing, which are both really important. And it took me to you know, a couple of other experts on this topic and on change in general. And I'll just make a couple of those comments. That there's a Harvard Business School guy, John Cotter, who has studied organizational change in lots of contexts, especially in businesses. And he wrote an interesting little article that was called "Why Change Efforts Fail." And he listed 10, it's in the Harvard Business Review. I think you can find it if you search for it. But the one that I was really struck by was, I don't know whether this was the first failure that he described, but it was failure to communicate the need for change by a factor of 10. By a factor of 10. And so, we're all busy. We've got lots on our plate. Whatever our plate is, there's lots of stuff on our plate. And so the idea of taking something new on is really a challenge. And so obviously I feel strongly that this should be one of the things that we're taking on. We're losing our patients, we're losing our friends, we're losing, I don't know, we're losing life by not taking it on. But it's not for the faint of heart. And so sitting in that space of sharing and developing commitments that are going to be enduring is really important. And then this is also going to be hard work over a long period of time. So starting right is really important. But as another one of our colleagues, Becky Stoll, who was one of the first people to take the work that Ed and his colleagues had done and sort of help us build what became the Zero Suicide Framework, Becky always says, this isn't a sprint, it's a marathon. And so you've got to stay with it. And what I'd really reinforce what Ed has said about measurement and quality improvement. There's the adage that what gets measured gets done. But particularly when you're trying to change something, you've got to, we know that when you're trying to change something, giving people feedback that shows that some changes, their efforts are resulting in something is really important. So, look at this. We went from completing screenings 60% of the time to 90% of the time in the last 3 months. And that is remarkable. And let's understand that and appreciate it. So the urgency in starting the change process, the discipline to continue it, and the thread that runs through this of having a measurement of what we're trying to do inform that is really important. So those are just some of my thoughts about the process.
Fantastic. This is our last question. Thought I might dive in a minute here and get a little juicy, if you will. But I'm sitting here with two subject matter experts and just giants in the field, and I can't help but wonder, you've been across the world with this, across the country, help implement it in all kinds of systems. And how has this, helping folks, learn about this framework and this movement, how has this changed you? You've both touched on that a little bit. And what have you experienced and seen? Does this framework and this dedication to end suicide really change systems and lives and save lives? So Dr. Hogan, I'm going to come back to you on this first, and then we'll end with Dr. Coffey's thoughts.
Well, thank you, Jenna. The thing that actually comes into my mind in response to your question, and again, as I said in my talk earlier, I came at this as a general mental health person who was getting more and more frustrated at our failure to do anything about suicide. While we were doing various things, or mostly doing nothing at all, the rates kept rising and people kept dying. And you can't be in a position of leadership or supposed leadership without incident reports coming across your desk. By my estimate, while I was in charge of various mental health systems, or allegedly in charge of various mental health systems in different states. About 3,500 people died on my watch. And you can't not feel some sense of urgency. So it was all that led me to on this quest to figure out, well, what might work. Thank God that quest led very early on. This was right when Ed and his colleagues were publishing their initial results, which reported, truthfully what the data were at Henry Ford. And their effort, as I said before, became the most successful suicide prevention effort that the world had ever seen. If you measure it by outcomes, by the degree of reduction in deaths, this is the most successful effort the world had ever seen. So successful that a lot of people in suicide prevention immediately started saying it can't be true. The numbers, the books must be cooked. There must be something wrong. And of course, Dr. Coffey and his colleagues went back and looked at the books and found out that the numbers were right. So it was inspiring to find that there was a way, there was a path to save lives. And the second thing, if I could go on this for just a second longer, that has been reinforcing to me was through doing this work, meeting so many people who have lived with suicidal thoughts, in many cases made suicide attempts and came through them, and have begun to teach us about that, have begun to teach us, for example, that people who die by suicide generally don't want to die. It's not a choice. It's not a romantic thing about, shall I live or shall I not? It's a decision that takes place with great pain, usually in isolation and in desperation, because there's nothing else that people can think of other than this, this false solution. But meeting, so many people who have survived, are glad that they've survived, and have begun to communicate so much to the rest of us, has been, in some ways, has been the greatest gift that I've gotten back from this.
Dr. Coffey.
Yeah, well, that's an answer that's hard to follow.
I know. I'm like, okay.
And I agree with what Mike said. It's an interesting question, Jen, and I thank you for asking it. My involvement in this at whatever level, whether I was leading the effort to continue forward or helping others do the same work, learning from others and work that they're doing, has helped me improve. It's helped me improve as a clinician. I'm a better caregiver as a result of every interaction that I've had around zero suicide. I'm a better listener. I've begun to understand, I'm not saying I'm all the way there yet, but I've begun to understand what it means to have the care centered on the patient and the family, as opposed to centered around my schedule and what I'm doing and what I think is important and so on. It's made me a better clinician scientist. I'm looking at issues that maybe touch more people more directly than the stuff I used to do, obviously. And hopefully all that's made me a better person as well for the same reasons. Being a good person and being a good leader, those are very, very close to being the same kinds of things. And so it's just been incredibly rewarding. It's been a reset for me, really. I mean, as Mike said, I was on one path that was fine. It was academically successful and I was doing okay. A complete reset. And I had no idea about where it was going to go and how fulfilling it would end up being. And that's not to do with me, it's to do with the work and the people, as Mike said, that you come into contact with who want to do the same kind of work. And so I'm just, every day I just give thanks for express gratitude for the opportunity to engage in this work and to meet others who want to do the same thing.
Yes, thank you so much. Oh, thank you both so much. I'm so, yeah, myself also very grateful for you both coming and being so candid and open, and for your experience. I will, as promised, open it for a few minutes. Those that need to leave time, we are actually exactly on time. So please feel free to log off and go about your day. Both of these gentlemen have agreed to stay for just a few minutes for some of these questions. Greg, if you don't mind coming on and.
Yeah, not at all. We have a couple of great questions here. So
Okay, great. I'll
start-
unmute and let you take those.
sounds good. We'll start with number one. Healthcare providers are experiencing pressure on their resources, especially exacerbated during the COVID-19 pandemic. Healthcare systems are fragmented and distracted. So what are the immediate obstacles to convincing healthcare leaders to take up zero suicide? And practically speaking, how can those obstacles be overcome? Symposiums and conferences are great, but how do we generate tangible action and meaningful movement by healthcare leaders?
You know, I'm channeling another noted expert in change as I think about that question, which is Yoda, who famously said something like, "There is no try. There is only do or not do." And that's kind of what I feel like about this effort. It doesn't mean that it's easy. It doesn't mean that the results are going to be that dramatic. Even in our settings, suicide is a very low frequency event, and reducing a really complicated low frequency event is a very hard thing to do. So, there are lots of reasons to not do this, I guess. I sound a little Eeyore-like, I guess, in going there. It's too hard. We're too busy. We might not succeed. But all the reasons to not do it, it seems to me, are, at the end of the day, I have to be blunt about it, they're kind of weak. And they focus on our convenience. And suicide is the signal reason for mortality in our work. And if that's what it is, I think we have to start down that road, even though it's a hard road, it's a long road, it can be a lonely road, and we will experience bumps and bruises and failures along the way.
Yeah, yes, I agree. And I agree with the premise of the question. There are just enormous challenges that healthcare providers and leaders are facing today that it's only gotten orders of magnitude worse with the pandemic and everything else that follows from the pandemic. At a practical level, I think we have to show some empathy for our leaders, and we have to appreciate they're under pressure just like we are. And so we need to try to help them solve their problems. And if all we do is go to our leaders with more problems, I don't think we're going to help anybody. So what I've tried to do is point out and help others point out that doing the value added from doing zero suicide is more than zero suicide. If you get into a groove where you are improving your system of care to a level that you can actually impact suicide, you're going to be improving many, many, many things in your system. And the return on that investment is going to be through the roof. So I think as we think about this work and as we prepare the work, if we just make those ripple effects more apparent to our team and to the system we're operating in, it has an added level of importance, and it can be seen as a way to solving other problems. For example, we had an access problem. Okay, we're going to have to fix access if we're going to lower suicide. So let's get on that. And how do we manage suicide risk? What do we understand that risk to be? How does that get implemented in primary care? Well, but guess what? We don't have a mental health system in primary care. So what do we need there, right? And by the way, the ER is a mess. So all of these things, ripple effects from the zero suicide work, and added value to our system above and beyond the important value of saving lives that Mike mentioned a moment ago. So we live in a political world. We have to understand there are political realities, and we just have to try to get as clever as we can be about how to navigate those realities, and honestly and sincerely, not playing games, but doing it the right way. So I think maybe taking that approach, demonstrating the extended value added, trying to help our team and our system might be one way to help get more rapid adoption of efforts at eliminating suicide.
And I do want to say quickly, Greg, before you go on, some of our tools here in New York, that if you will look at the resource page for this, and if you can attend some of the other events, there are some very practical tools that will be discussed, and systems level change agent information. And we do have a toolkit to accompany this about how to start for New York State. And then there's also all the national information that will be reviewed. And we are inviting healthcare systems specifically to join us in a community of practice where monthly we will review the exact sort of how to implement and to do this work. And there will be more about that on Friday in the call to action. So I do believe if you stay put for the content of this conference and symposium, that answer of the how will be answered. So I believe we have time for just one more question.
Okay, the defect-free depression care project was impressive and led to briefly achieving the goal of zero suicides among HF, HS, HMO members. Centerstone also achieved similar results, but in both cases, and in the Air Force too, results were not sustained. For the benefit of our grant sites that have been working at this for 3 or 4 years now, can you talk about keys to sustaining optimal suicide care?
Well, a good question. I would just maybe quibble with the premise a little bit. We actually sustained our results for the 10 years that I was there. So I do think it's sustainable. I agree with what Mike said earlier. You have to build in sustainability at the beginning. That's not an issue that you focus on down the road. When you do your planning for any project, part of that planning involves how do we sustain it? How do we keep it going? And indeed, how do we keep it improving? So I think that's key. Many projects run out of gas because they weren't designed with sustainability in mind. And you can Google sustainability and you'll find a wealth of resources on how to think about this matter going forward. Now, that said, it is hard work. It is very hard work, as Mike mentioned. It is not for the faint of heart, as Mike mentioned. Not everybody necessarily gets on board with this kind of work. So you have to recognize that. But I think if you begin the planning with sustainability in mind, your chances of maintaining that benefit are dramatically increased. I can't speak to the Air Force data, exactly what happened there. But I think that's an essential issue, planning for sustainability.
Well, let me pick up on that, Ed, I've looked at the Air Force situation a little bit and then the Centerstone one as well. So in the Air Force, it's a very interesting story. There was a leadership change across the top of the Air Force. They kept the suicide prevention protocols in place, but they took their foot off the pedal with respect to the urgency of leadership communications and quality improvement. Bam. And so it was a failure to sustain the urgency and to sustain the measurement and to sustain the focus. So this is not something that can just be like done by switching a protocol switch and expecting it to work. The Centerstone story is interesting as well. They were coasting along, doing fine. They'd achieved something like the results that you had at Henry Ford, that is having reduced the suicide rate in a population of people getting behavioral health care to somewhere around 15 per 100,000, which is actually lower than the general population level in their communities. So quite commendable. And then it skyrocketed up again. And they were blown away to discover this. They thought they were doing the work. And when they went deep into what the data were saying to understand what was going on, it turned out that the increased deaths were among people who were not on their suicide care pathway. Well, how come they weren't on their suicide care pathway? They were mostly, the bolus of those deaths were among people who were getting what's called, medication only care. They were coming in for brief visits just to get a medication check every 90 days. And they weren't getting other kinds of counseling or therapy or psychosocial support. And unwittingly, some people were doing this by choice because they didn't want it, which didn't mean they were doing well. It just means they didn't want the inconvenience of, having to talk to somebody. And other people were being put in there without adequate risk screening. So they essentially tightened up on those practices, and the numbers came back down again to where they were. So it's follow through, it's discipline, it's sustaining urgency, and above all, it's quality improvement that's focused on the right things that has made the difference, or the failure to do that, which has made the difference in the wrong direction.
Okay. Oh, I would like to thank you both so much, and apologize for the two questions that we didn't get to answer, but we are out of time, and I want to close on time and be respectful of everybody else's time. And we do start tomorrow again promptly at 8:30 a.m. And we will follow the schedule with each speaker starting on the hour and ending 5 minutes early, so that you can have a small break to get to your next session. And we're very excited for our day focusing on cultural responsiveness and equity within healthcare tomorrow. And we will go until 12:35 tomorrow. So we will see you then. And we do have our final day after that. So take care, and we will see you tomorrow. Thank you.
Thank you.